Good evening, everyone. My name is Kay, and I'd like to welcome you all and say thanks so much for being part of Musculoskeletal Australia's community webinar series. On behalf of Musculoskeletal Australia, I'd also like to acknowledge the traditional owners of the lands on which we're all meeting today and extend our respect to all elders and welcome any Aboriginal and Torres Strait Islander peoples who have joined us today. So today's webinar is on the topic, working well with your healthcare provider, something that is essential, particularly when living with a chronic health condition, but sometimes can also be challenging and overwhelming, which then has a real impact on how we receive and process information and even make decisions. And so to provide some tips and strategies around planning for appointments, being emotionally aware and prepared, and effective communication, we're very thrilled to have Miss Bridget Scanlon join us tonight. So thank you, Bridget, for your time and support in joining us this evening. Bridget is a psychologist who is committed to working from the biopsychosocial model of health and works as part of a multidisciplinary team at Empower Rehab. Bridget is also committed to helping clients understand their mind-body connection and developing their confidence to cope independently, and so is expertly placed to talk us through this topic as well as answer any questions that you might have. So we really encourage you to please use the Q&A or the chat functions to send us whatever you might be thinking about or wondering about. Bridget is ready and available to answer those questions for you. And so on that note, thank you again, and over to you.
Thank you, Kay, and good evening, everybody. It is an absolute pleasure to be able to share and go through some of this information with you tonight. I am really pleased that there are people here who are willing, because I do really believe that we often get our best outcomes with our patients and our clients and our consumers when we're all on the same page. So I think if you have chosen to take on this information tonight, you're already starting to do that. So that's really wonderful. And I do want to reiterate what Kay has said, that questions are really welcome. And feel free to, at any stage, just pop them in and we'll make sure that we leave some time at the end to be able to address those. So I think it's perhaps helpful just to give some context around me and my work. So then when I'm going through some of the information tonight, you can almost picture me at work and how this might come into play. So then, when you go into your next clinic setting, you can kind of start to see hopefully your health professionals in this way a bit as well. So yes, I work at Empower Rehab, and we are both a multidisciplinary clinic and an interdisciplinary clinic. And the slight difference between the two is that multidisciplinary means we have several disciplines of health practitioners. So for example, physios and psychologists working in the same clinic. So the interdisciplinary part means that we actually are often in the same room together with our one client or our one patient. So I work with physios and our pain specialist face-to-face. So we have sessions all together. So sometimes, we can have 4 people in the room when we are working with somebody. Also too, with clinicians who are outside of our clinic, we often have perhaps a specialist, on telehealth with the client and myself in the room, and we work like that. And because from my perspective, and I guess when I'm working with people who have persistent pain or any kind of chronic health condition, yes, the pain or the condition may be experienced in one particular part of the body. Let's say, for example, somebody has shoulder pain. They're not just a shoulder walking around. There's also a lot of the rest of them that is associated with that shoulder. And so we really need to take into consideration what is happening for the whole person whilst they are experiencing the pain or the discomfort or the illness in whatever part of their body. So if it's not persistent pain, then certainly there are other chronic health conditions that I work with. And so because of that, pretty regularly I'm speaking with other types of clinicians because I need to. I am not a rheumatologist. I am not a neurologist. I'm not a physio. I'm not an osteo. I'm not a GP. So I really need to be able to speak with those people who are part of a treating team. And as Kay has mentioned, I work from what's called the biopsychosocial model of health. And as I often say to my clients, psychology likes to put fancy words on some pretty straightforward stuff. And I feel like this is one of those examples. But essentially, the biopsychosocial model of health is one that needs to take into consideration the biological, the psychological, and the social factors and their complex interactions in understanding somebody's health, their illness, and their healthcare delivery. And so that if we can have that picture, if we're trying to understand what somebody is presenting with through that lens, we can ideally get a more realistic or a better outcome. And I always say too, with my clients that I work with, I'm working to do myself out of a job, that we will get to the point where life may not be perfect, the condition may not be cured. However, I would ideally want for people to feel more confident to cope with whatever it is that is going on. And so we need to be looking at what is going on for that person through that biopsychosocial lens to give them more of a chance for that to happen. So it is a mouthful, but it is actually really helpful and very effective. And I find that when we speak with people about this biopsychosocial model, they can relate to it and they can feel quite, in a way, relieved at times that how their health professionals are taking into consideration more than where they may be experiencing their pain and condition, and that it actually has other effects, which also understandably would be impacting their functioning, which we want to help them improve. So that's just for you to hold in mind when I'm going through some of this information, so that you can picture, I guess, how that might impact the way that I work. So here's just a really nice kind of basic outline and examples of some of the things that we can see as part of the biopsychosocial model of health. Certainly the biology part is something that you may get a lot of information from your specialists in a way. I find it really helpful when I'm in conversation with, say, for example, physios or rheumatologists, that they can provide me with some of these explanations of how this element of the person's presentation is happening. Though then we can start to have a conversation about, oh, okay, so if, for example, somebody has, you know, ligament issues or their stability issues in one of their limbs, then we go, okay, and how has that been affecting their ability to exercise or to get to work? And well, actually, it's been really difficult, and now they're also feeling quite stressed about it. And because they're stressed, their muscles are contracting more. There's also more cortisol going through their system, which means their pain levels go up. So that's an example of how we can start to see all of these interactions and why we need to get a bigger, better picture of what is going on for someone when they come in and tell us about one part of their body. So I thought it might be a bit sneaky for us to maybe take a little peek behind the curtain of what are the clinicians digesting in terms of information. What are we asking? What are we thinking about when we're meeting a patient, or when we're trying to come up with treatment plans, or when maybe we're stuck with somebody where we're not getting the outcomes that we would expect? There's a couple of things. So certainly what I would say, the kind of really foundational information is important. So any referral information we would have gone through, we would look for things like, though, I like to look at, you know, how long has this person been experiencing this health condition? How many other clinicians have they seen? Because I think we clinicians, sometimes we see ourselves as being, you know, pretty special, and because we would like to help people, and so we can be really optimistic and think, yep, I'm going to be the clinician that's going to be able to help this person. Though there are thousands of other wonderful, capable, very talented clinicians too. So it's helpful to go, okay, this is interesting. They've been to X amount of clinicians. Why might that not have been helpful for them? And that's quite common from where I work. On average, people we see for persistent pain have seen 11 clinicians before they've got to us. what that also means is there's lots of different bits of information that would have been discussed with the patient prior to them coming to us. So what we really like to ask clients is, what do they think is going on? What do they think is the reason for the ongoing pain or the ongoing difficulty? Because it may not have actually been directly asked and may not have been directly ruled out. So from particularly when there is someone presenting with persistent pain, at times people feel like something has been missed or there is something that is broken or damaged. And so it's really important that we then go and make sure we've got information to check whether that is the case. The other thing, and we often say to our clients at assessment, we've got this $1 million question. We say, why are you here and why now? And often people say, because someone told me to, or because I have to, or they say, because I don't know what else to do. And I find those bits of information incredibly helpful to know where they are in terms of their engagement with treatment. And this comes from another model, the Readiness for Change, which is based on a trans-theoretical, see, fancy words, trans-theoretical model, which is proposing that when there is a need for a behaviour change, particularly in regards to a health behaviour change, so say, for example, quitting smoking, that we move through a series of, or a series of stages rather than the change being all or nothing. So these stages, they're called, so there's pre-contemplation, contemplation, preparation, action, and maintenance. So at assessment, when we're with our patients, we do like to try and get a bit of a sense of where are they at in terms of readiness to change. Is this someone who's in pre-contemplation? Because if they're pre-contemplation, they may really just be gathering information. They might just want to get an understanding of what is it that the treatment that we have to offer. And so that's maybe the best or the most that what they need from us at that point in time. Because if we then jump into starting to talk about action, starting to talk about treatment plans, which is much more the preparation and the action stage, or even we start introducing some ideas around the strategies that we'd be recommending, but they're actually at contemplation, we're not really setting them up for success. So as clinicians, it's really helpful and important when we're meeting somebody and or as we go through treatment as well, we keep checking, where are they in terms of readiness for change? Because I know, I've worked with specialists who have, particularly doctors, where they're recommending a course of medication or maybe another kind of intervention, whether it is an injection or surgery, and that the recommending specialist is really certainly quite keen and believes in what they're recommending. However, the patient's hesitant. They're, at this point in time, they're not as excited or enthused about the recommendation as the specialist. And so then we need to, well, perhaps they're not quite at action stage yet. Let's try and kind of come back to maybe they need preparation. Maybe it is that there's lots of planning that needs to come into this. And that may be a part of the social elements of the biopsychosocial model. So this is something else that as clinicians, we really want to be checking for, and something that your clinicians might be checking. So if you feel like maybe they're holding back on information, perhaps your clinicians are perceiving you at contemplation. But is there a way that you can communicate to them that you feel ready to take action, that you have made plans for how you could be able to follow through with any of their recommendations? So just something for you to hold in mind, and even for you to start to kind of inform yourself, what is this stages of change? Because you can also use it as a reference point for yourself to notice, okay, well, where am I at? Am I really ready to follow through with some of the things that have been recommended? Does it feel possible to follow through with some of the things that have been recommended? And again, that comes back to the biopsychosocial model. If what is being asked of you feels incredibly overwhelming, then perhaps you're less likely to be able to put things into place for that to happen. So maybe we need to help you with that feeling of overwhelm and help you with the planning part as well. The other thing that as clinicians we are thinking about, but maybe we don't always communicate well, is all treatment, regardless of what it is, whether it's surgery, whether it's talk therapy, you know, with me, something like that, there's always going to be a side effect and hopefully some therapeutic benefits. And we always want the therapeutic benefits to outweigh the side effects. So for example, for someone to come and work with me, if they're privately funding, I would see that sometimes one of the side effects is the cost, okay? That, you know, unfortunately, we aren't a free service. And so that is a side effect. And maybe too, it's the distance that someone needs to travel. And because of their pain, they're actually not able to travel. So then, because if someone is turning up to sessions with me and those side effects are so significant that they're incredibly stressed whilst they're attending an appointment with me, any benefit that they may get from working with me is already diluted. So we need to have a conversation with our clients around, you know, this is what we see as the benefit, right? And this is why we're recommending any treatment for you. We also acknowledge that these side effects also exist at the same time. Does that ratio sit comfortably with you? You know, because no one can make you have any form of treatment. So this is a choice. And, you know, if that space between the therapeutic benefit and the side effect sits comfortably with you, then let's do this. If it doesn't, okay, let's see. What are our options here? You know, is it about timing? Is it about, you know, the frequency of appointments? Is it, you know, even timing in the month? You know, if you know that there are easier times to be able to attend. That they are things as a clinician we hold in mind. But again, I'm not sure that we always do a good job of discussing that with clients. But we know that if we have a good idea of that, again, we're more likely to get the good outcomes from the client. So I think as patients, as consumers, as clients, feel free and feel comfortable to check that both with yourself and also with your clinician and go, can we just, it's almost like doing a pros and cons list and really explicitly just list out, okay, what are the pros here? What are the cons? Does the balance of that sit comfortably with me? And, you know, if your clinician doesn't have time to do that in session with you, I absolutely think that's something that you could possibly give yourself time to work through and take it in and say, hey, look, this is what I've come up with. Would you make any adjustments or additions to that as well? I think we, particularly I guess where we work, but I in my interactions with a whole range of clinicians over many, many, many years, is that when we ask the question, do you have any questions? Unless it's, you know, maybe 4:55 on a Friday afternoon, we genuinely want to know, do you have any questions? Because, and this is something I say to my clients, you know, I can't read minds. So it's very helpful for me to know what questions you might have for a few reasons too, in that it's not just the content of the question that might be helpful. It might be even the timing of the question. Also, for example, let's say I've gone through explaining some really helpful exercises and strategies that can help calm down your central nervous system, which is really helpful for pain. And then the client's nodding, and I'm thinking this is really resonating with them. I feel like they're keen to try this. And then I say, you know, do you have any questions? And they might say, oh, I read this book last weekend about how I can manage my pain. Have you read this book? And there's a part of me that goes, oh, are they asking me that question because they haven't been listening, which is absolutely possible, for the last few minutes about the information that I've had? Or is it because they're not actually on board with what I'm recommending? They would prefer to go through the information that they've read in the book, for example. So any questions, regardless of whether it's what we expect or not, it does give us an opportunity to kind of seek out more information from them. I say all of this knowing too that there is lots of variation in what each discipline or how each discipline approaches things, i.e., you know, physios are going to be coming at things slightly differently from psychologists, and again, slightly differently from the pain specialist, and again, differently from the surgeon or your GP. And also too, within the discipline of psychology, there's also going to be variation with what one psychologist or how one psychologist approaches things to another. So how I'm speaking about things might not be how everybody does it. However, we do know that, well, one, no clinician can read minds. So it's always helpful, you know, to be able to ask those questions and to put information out there. And also too, that if the clinician, for whatever reason, isn't able to hold the space for you to ask questions and hold the conversation, create that space somewhere else. So, you know, I know lots of clinicians where their appointment times are short, but they are really open to people sending an email before the appointment with all the questions that they want to make sure that they go through in the appointment. Or maybe it's an email that gets sent after. Or maybe it is that they have particular, you know, they make a double appointment so they can make sure they have more time. So it may not be in a clinician's default repertoire to kind of allow that space for questions, but it's something that you can create and something that I will really encourage you to create. The other thing too is that we know that, or we kind of expect that people are going to come into appointments with us on a range of anywhere between super cautious and maybe skeptical to incredibly enthusiastic, keen, you know, will agree to anything we say. And so we will try and work out where people are sitting on that, and again, modify what information we're going through, and also how we're delivering information, the pace of things, depending where you're at. So don't expect yourself to be at any particular point. There is no one state or stage or presentation that we would expect anybody to be at. We kind of, all we expect is that people are in this range somewhere. And also too, that you might move within that range over time with working with you. So that's a little bit of, you know, some of the things that we consider. I guess then these are just some prompts for what might be helpful to hold in mind as you're going into appointments with your clinician. One of the, so I've put here to know what your expectations of the clinician and or the service are before you go. So this is partly, when I say expectations, I'm referring to this concept in psychology we call psychological contracts, which essentially just means that in lots of interactions or relationships, we bring in an assumption of something that is agreed on within this relationship. And that can be in a personal relationship, it could be in a working relationship, it could be in a family relationship. We also know, though, it exists within treating health practitioner and patient relationships. So, for example, someone might have the expectation that their clinician always asks them how they are and is friendly. Okay, so, and that's absolutely reasonable for someone to hold that expectation. However, it's not necessarily something that every person has explicitly signed up for, in that your clinician might not agree or might not hold that expectation either. They may have the expectation or the psychological contract that we squeeze out as much information or as much action in this session as we possibly can. So I don't have time to ask the person how they are. I'm just going to jump in. So though, if I'm holding that contract that my clinician is going to ask me how I am every time I go in, and then they don't, they've essentially broken a contract with me. And instantly then that can change how the dynamic exists between myself and my clinician. Or it might be that I have the expectation that my clinician will be able to have, fix everything. And that may not be your clinician's expectation of what treatment is going to do. It hopefully is going to help, but it may not necessarily always be a cure or a fix. So it's really helpful to check before you go in. What's your psychological contract with your treater? And this isn't about what's right or wrong. It's more around just checking with yourself, what have you assumed is going to be available to you in this interaction with your clinician? And if that clinician isn't able to meet your psychological contract, is that one that you are willing to compromise, negotiate, or is it one that you can kind of put down the list of priorities? Perhaps it is that you go, look, it's actually more important for me that my clinician listens to me and gives me space to ask questions, but I know they don't run on time. And I'm okay with that. I'd like them to run on time, but I realize that that's not something that this clinician has kind of signed up for. So I'll just need to kind of put that down the priority list that they run on time. The other thing too is just to kind of check what I know at times we have had clients referred to us and they will have an assessment and they assume that they are, I guess from the information that they've been given, they thought that coming to us for an appointment or us for an assessment means that they were going to have some kind of intervention, which is certainly not what we would do at an assessment. And understandably then for them, it was an incredibly disappointing appointment. They thought that perhaps they were going to get some kind of injection or another kind of intervention, and that was not what we offer at assessment. So just, checking beforehand, and even too as a clinician, making sure that our administration team, when they're providing information about what the assessment might look like, that we're making sure that we're giving people that information so that when they arrive, they're, there for what they thought they'd sign up for. And then that point I've written there about clarifying passive versus active treatment and who is responsible for what. So passive treatment is any, I guess we can think about it as any treatment that is done to you. So it might be even, like I said, an injection or even hands-on therapy. That's passive because it's being done to you. You don't need to do anything necessarily in that moment. Versus active treatment, which is what can you do that helps you with your recovery or your rehabilitation, and working out who is responsible for what. Because, for example, the physios I work with, particularly when we're working with persistent pain clients, they're hands off. So they don't do any hands-on therapy. However, they teach our patients how to replicate what would be happening when you get a massage, and people can start to use certain kind of props or tools or pieces of equipment that can do that. So then they don't need to go to get a massage or to be manipulated, that is something that they can do independently, and that is active treatment. And what we notice though is that, particularly say for the physios, if someone has come in with a psychological contract, that when I see a physio, they will put their hands on me and help me, and then our physios say, actually, that's not something that we recommend for persistent pain, it can be a really confronting and potentially uncomfortable conversation. So it's a really helpful one, because then it opens up the door for giving this person information about why that might be, and there are other options in addition to getting hands-on too. And that is a nice little segue into this next point, this idea of putting you in the driver's seat. Because again, what we observe with people who have any kind of chronic or persistent pain or health condition, that because of the limitations that pain or that health condition has put on and does put on people, that it feels like the pain starts to be the deciding factor or deciding part of them about what they can and can't do. And what we want to work towards is we don't have a cure for persistent pain, unfortunately, at the moment. What we can do, though, is work towards you knowing what you can do, so you can start to decide what is safe, what is helpful, what is productive for you to do. That does help reduce your pain as well. And then this next point is what's helpful for you to know is, I think, really about how do emotions affect information processing and decision making, which is where I like to refer to the hand brain. So I'll go to the next slide. You can do this while I'm talking and play around with it if you like. So this is something that Dr. Dan Siegel created, and he has a very, I think it's a great joke. Says, wouldn't it be handy to have a model of the brain with you? Do you know what? You've got a hand model of the brain with you. So what we think about is if these 4 fingers here, that represents the cortex. So if you could imagine a picture of the brain, you know, the wiggly grey bits, that's these 4 fingers. And that's this kind of the cortex here, which is particularly where we do lots of organizing of information. We call it the executive functioning. So where we take in information, we kind of, you know, roll it around, we get ideas, maybe we're problem solving, and then we kind of put the information back out. That's happening in this frontal lobe here. And then you can see this, if we imagine my thumb is a structure called the hippocampus, and then down here is another structure called the amygdala. And these, hippocampus is predominantly involved in memory, amygdala is predominantly involved in emotional activity. And, you know, as you're moving through your day, these parts of your brain just really kind of activate each other and talk to each other really well. So at times, if there is higher or very high levels of emotional activity, it's almost like we flip our lid. And the emotional activity is so intense that the brain goes, mate, we don't even have time to think this one through. Just react. Just do something to respond to whatever this emotional activity is. And so that's why at times, you know, if we're really frustrated, maybe we'll say something we didn't actually mean to say. Maybe when we're feeling really desperate, we say something that's not actually my intention. You know, maybe it is when we're really sad and we're feeling quite hopeless, we just say, oh, what's the point? Doesn't really matter. Because that's just this kind of amygdala is just in overdrive that we haven't actually been able to engage our thinking brain. And so the other difficult thing too is that pain, because pain is a protective response within our body, it's an attention seeker. It just gets to kind of trump everything else that might be being considered in the frontal lobe. And the other thing that happens when your pain levels go up is because it's protective, so does your anxiety levels. And so again, heaps of extra activity happening here. Thinking brain, she's out. So we need to find a way to re-engage this thinking part of the brain again. And one of the most effective ways, it sounds simple, and in a way it is, but sometimes it's hard to do. But one of the most effective ways to re-engage that is to calm down your breathing, because that sends signals back down to the central nervous system that we are steady, we are safe, regardless of what's going on around me, I can do this. And what we know is even if you do 10 slow, deep breaths at 3 seconds in, pause, and 3 seconds out, that is enough to start to slow this down to get this back in, okay? I even recommend sometimes clients when they're going in to maybe see a specialist, or maybe they've got a really difficult appointment coming up with someone else, or maybe it's a meeting or something else, that they kind of just be pumping their hand just as a reminder about what might be going on in here. So I've thrown a lot of information at you. So your prefrontal cortex and your frontal lobe is working in overdrive. Taking all of that information on board, what would then I be recommending? It's these things. The writing down the questions before your visit, again, is partly because you're probably more grounded, more settled, more calm before you go into an appointment. And the other thing too, we find with the act of writing, it helps with reducing what we say is rumination, which is really just overthinking. You know, so often questions that people can have when they've had a chronic or a long-term health condition is, you know, when is this going to get better? Is it always going to be like this? Is anything really going to help? Is this what I always have to do? Those are really difficult questions that I'm not sure anyone can answer, but the effect of asking those questions contributes to a sense of anxiety and uncertainty. If you write them down, because they're valid questions and probably worth asking somebody, the act of writing it down signals to the brain that that thought has been clocked, or it's been, you know, we're aware of it. Therefore, it doesn't need to kind of push the urgency of you staying on that thought. So I would even encourage you to have, you know, whether it be a notepad that you carry around or a notes page on your phone or a draft email, that whenever a question pops up, that you can jot it down there so you don't need to keep carrying it in your mind. Because the other thing, remember hand brain, your hippocampus, it can only hold so much, and we all overestimate how much our memory can do. And again, when you're in pain does affect memory function, and so we kind of still expect our memory to be able to do what we want it to do or we need it to do, where it's probably not going to be able to do that. So having, in a way, an external memory, which is a to-do list, which is a diary, all those things are still really helpful. As outdated as they might seem, they're always going to be helpful, and you're more able to engage with those when you're outside of the pressure situation, which might be your appointment with your clinician. The other thing too, think about what's important to you. And again, that comes back to, what's your motivation for being in the appointment that you're in? What are your psychological contracts or expectations of treatment of your clinician? And if they're not able to meet all of those, is that going to sit comfortably with you? Is there a way of reprioritizing? And that's where, I guess, in a way, the working through some acceptance as well, and even a way, even some disappointment if what treatment isn't, if it's not going to be what you would like it to be. If you're not confident that you will be able to recall and retain the information that's discussed in the session, ask if it's okay to bring someone else with you, or if you can actually record the session, say for example on your phone, or if you have another way of recording, just make sure that you do get permission if you're going to be recording anything though. Be honest as best as possible. I know it could be intimidating, and even me when I'm a patient, I know I'm not as assertive as I think I can be in other situations, though I just keep reminding myself that my doctor can't read my mind. I need to make sure that I'm just putting this out there. It's important that you feel confident and comfortable and trust your health practitioners. That doesn't mean necessarily, though, that you're going to be pals or, it's always going to be a enjoyable experience. Though I know that as the clinicians, again, that I work with, and all of them that I've come across in the years that I've been doing this, I think that's something that's really quite universal with clinicians, is that we want our patients to feel comfortable. We want them to be hopeful. We want them to be realistic. And so if that's not what's going on for you, I think it's really in your best interest and your treatment's best interest to let someone know. Again, taking into account your handy brain model, to be aware of how your emotions can affect taking in information, concentration, and making decisions. So if you need to give yourself 10 breaths, honestly, if that's going to be the difference between you taking on information and not, I would really encourage you to take those 10 breaths. And if you need to, in the consultation, you can say to your clinician, I'm just struggling to concentrate right now because my knee is just absolutely killing me. I'm just going to take 10 breaths. Your clinician will go with you. They might appreciate a moment to kind of collect their thoughts too. We would prefer you take those 10 breaths to be able to engage in that consultation than feel like you need to just push through because it's really painful, but you want to get this information, you've waited for this appointment for so long, etc. Build a support team around you if you can. Again, whether that's different clinicians with your consent, encourage your clinicians to talk to each other if they're not physically in the same place. And I think, that's happening more and more, particularly if it is a longer term presentation or condition. So let your clinicians know if you are comfortable, that they, provide them with your consent to speak about what's going on for you. And if you want to, you could throw in there the biopsychosocial model just to really impress them. Continue to talk with friends, family, and other people, particularly if they're people who may be able to relate to what's going on for you. Also, though, you can curate that, so you might know that there's some friends who are better to speak with, or some family members who you find more helpful than others. That's okay too. Just making sure that you have some people where you are able to talk these things through with, to prepare for appointments, to talk about what you're expecting from treatment, etc. And the last one is to educate yourself about your condition from reputable sources. And obviously we have one here with Musculoskeletal Australia. But again, asking your clinicians, you may find the sources, and then you might just want to bring it in and check with them and say, hey, look, is this somewhere that you would, encourage me or recommend me checking in with. You certainly don't need to wait for them to give you the resources, but at the same time, you can ask them if they have any recommendations, because I think we all know there's just an enormous amount of information out there, and not all of it's helpful, and also too, some of it's not delivered in a helpful way. So some people may have ideas and suggestions about the most accessible information, or even the more interesting bits of information. So keep asking and keep educating yourself on that. And again, just making sure that it is those reputable sources, so you can be confident and you can trust that information. So that is me. And I have really thrown a lot of information at you, and I can appreciate it's quite a bit to digest. But there are some key things, and I've really kind of given you the surface level and some pretty meaty things, but I hope that it can give you a few, bits of food for thought as you approach your appointments with your health professionals, and be reassured that more often than not, your health professionals, they want to be your hero. They want to help you, but we need you to help us help you. So please do remember that we can't read your minds, and all questions are in the end going to give us something. So I hope that's been helpful, and really open to any questions, or like I say to my clients, any yeah buts. So let me know, and that's me done.
Oh, thanks so much, Bridget. That was an excellent presentation. I learned a lot. I learned more about biopsychosocial, big word, but very, very relevant to all of us, really, whether we have a chronic health condition or not. But actually what you went through, I think, would definitely resonate with our community for sure. And they were really great, practical and positive points, but also very balanced in acknowledging sometimes the limitations that maybe clinicians have, or we ourselves as patients have. So yeah, really appreciate what you shared with us today. And I guess just around that, couple of questions that we have. You do say that we should ask questions, but really, is there anything that might seem unwelcome, unhelpful, or anything like that when we're in the appointment that maybe we shouldn't ask?
I mean, in short, no. And I think that's a really fair question. There's two things that I think about when you ask that question. One is, I guess, something that I mentioned before, that it's not always necessarily actual question that someone's asking, but it's, my mind goes, oh, I wonder why they're asking that. The other thing too is, I guess, again, it gives us as clinicians more information about those stages of change, kind of where are they at.
Yes.
And even to, let's say, the other thing sometimes, the question that's not welcome or not, appropriate. Like, I guess at times, if it was something about, me personally, but again, I'd just be really intrigued why someone's asking it, because I know a lot of our clients are really lovely people, and they worry that it's out of balance, in that we're often asking, about them and their life and how they're going, and they feel obliged to then ask us how we are and how we're going. And it's really important that as a client and a patient, that you don't feel like you need to be, thoughtful about us necessarily, that you can take that time just to think about yourself. So in short, no. So yeah, all questions are always going to be helpful and fruitful.
Excellent, thank you. We have another question here asking, are there any resources that you can recommend, or strategies or information that can help with calming the nervous system? So you talked about the breaths, just to in the moment, particularly if we're having bad experience with pain at an appointment. Is there anything else that you can recommend that could be helpful?
For sure. So many. I mean, as a starting point, even the Smiling Mind app is really helpful in guided relaxation exercises that we know are really effective for calming down the central nervous system. The other one is the Centre for Clinical Intervention, CCI, which is a part of Western Australian universities, and they have a heap of information sheets, but also they have some audio clips which go through some of these exercises. They have a really great diagram about what's happening with breathing, that it can affect, does affect and calm down the central nervous system. So that's probably the two. Start with those. The other thing too is, a little plug on Empower Rehab on our website. We also have some clips that you can access to that are helpful with that.
Excellent, thank you. And we'll certainly circulate just some extra info around those resources as well to help people manage what they're going through. And I guess just along that line, another question is, I guess sometimes our situation means that our health journey doesn't allow us to have a lot of choice as to who we see, or, a change in clinician. And so sometimes it's not a good fit. It's like they're not, we don't gel, we don't connect very well. So how do we manage that? Like, what sort of strategies, or if, the specialist is particularly not a great communicator for one reason or another, or dismissive, how can we help, because we have to keep going back to them for a period. So how do we work through that?
Yeah. And that is tricky, particularly if, choices are limited. I would recommend, again, coming back to that idea of, your expectations, and again, seeing if this, and, what we always want to do is work in reality. It's okay to hold your ideals though, so ideally you would like a practitioner who is a good communicator, or, who does actually listen and take on board what I'm saying, though that may not be your reality. So then going, okay, well, I guess I still need some care, and I still need some guidance, or I still need some treatment. But then kind of just seeing if you can work through compromise in a way with yourself that, okay, the ideal of them being a more perhaps empathic, or, a better communicator, that's not available to you. The other thing you can do is think about, I guess, assertive communication, and putting the formula in of when you do X, it makes me feel Y. So it might be something along the lines of, Bridget, when you say, yeah, that's fine, and then give me another recommendation, it makes me feel like you haven't quite heard what I've said. Yeah, no, I heard what you said. I've been listening to you the whole time. When you say that, it just makes me feel like you're not listening, or you're not taking on board what I'm saying. So trying to describe, their behaviour, as opposed to labeling, you're being rude or you're being dismissive, because if we can label the behaviour as opposed to the person, it can help diffuse and kind of depersonalize in not completely, but it's getting us to less likely for the other person to be defensive and to be a broken record. Excuse me. And even to put a suggestion in, to say, hey, look, every time you say, yeah, I've told you that before, it makes me think that you're not listening. You can check in with and say, what have you heard me say?
Yeah.
What are two things that we can agree on today? So finding 2 points of agreement, is sometimes a meeting point that you can reach when, maybe the fit's not great, or it doesn't feel like they're gelling, but working towards that. And again, just knowing that this is your appointment. If you're not feeling like, they're listening to you, bring that to their attention, because they may be oblivious to that.
Yeah, that's great. Thank you. Another question might be a little bit left of field, but do you have, or is there a place that people can go to look for psychologists that work within the biopsychosocial space, particularly in Tasmania? We've got one person wondering if there's anybody doing that sort of work in Hobart, or in fact, maybe other states as well, for everyone else who's listening.
Yeah, great question. Off the top of my head, I can't say anyone in particular, but I'm sure there are, because particularly if anybody's working in as a health psychologist or in a health space, they are likely to be working from that biopsychosocial model. The other thing that sometimes is a helpful way to find psychologists who do work from that perspective is to ask your other kinds of disciplines whether they have had any luck with a psychologist as someone that they've worked alongside, because that again, that would suggest that the psychologist is working from that biopsychosocial model. So for example, if you're working with a physio, ask them, have they got any psychologists that they've found helpful to work with in terms of a shared patient? The other thing you could do, excuse me, is look on the Australian Psychological Society website, which is psychology.org.au, and do find a psychologist. And they've got a really detailed list of options when you filter through. And biopsychosocial is probably not an option on the filter, but I know that, certainly chronic health conditions, and there may even be specific health conditions that you can nominate when you do the search. And so that might get you closer to, and certainly you can do it by location as well. So that might get you closer to finding a clinician who could work from this model.
Excellent. Thank you so much. I think we're probably just about out of time.
Yeah.
So we might leave it there. Thank you to everybody again who sent in some questions, and we will let everybody know, like once the recording's available, we'll send out the link with some of those website and other references that Bridget mentioned, along with our own. We have some self-care plans to help manage various conditions which might relate to you. So we encourage you to also visit our website and check those out as well. Again, thank you so much, Bridget, for making yourself available. Really enjoyed your presentation, learned a lot, and it's definitely a resource that we will be happy to share within our community and beyond. So yeah, really appreciate you coming along tonight. Again, thank you to everybody else. And on that note, wish you a very good evening and hope to see you again at the next one. Thank you, everyone.
Thanks, everybody. Take care of yourselves.